altitude-related hypoxia, pathophysiology, diagnosis, and evidence-based management. High-altitude exposure affects greater than 140 million trekkers annually, leading to acute mountain sickness in up to 30% and life-threatening high-altitude cerebral or pulmonary edema in 0.5 to 6% of rapid ascents. The primary mechanism is hypobaric hypoxia causing alveolar arterial PO2 gradients, sympathetic surge, and maladaptive pulmonary vasoconstriction. Diagnosis hinges on the Lake Louise Score, greater than or equal to 3 with headache, and bedside pulse oximetry less than 90% at greater than or equal to 2,500 m, immediate descent, supplemental O2, and acetazolamide 125 mg PO TID constitute first-line therapy, while dexamethasone 4 mg 4Q6H or nifedipine 30 mg PO TID prevent progression to HACE/HAPE. Key points. Note: acute mountain sickness, AMS, develops in 30% of individuals ascending to 500 m within 24 h. Incidence rises to 70% when ascent exceeds 1000 m per day. Wilderness Med SOC 2023. High-altitude cerebral edema, HACE, occurs in 0.5 to 1% of rapid ascents, greater than 4000 m, and carries a 30-day mortality of 25% without treatment, WHO 2022. High-altitude pulmonary edema, HAPE, incidence ranges from 0.2%, gradual ascent, to 6%, rapid ascent greater than 4000 m, with untreated mortality 5%, U.S. Army 2021. Lake Louise AMS score greater than or equal to 3 with headache plus greater than or equal to 2 additional symptoms yields a sensitivity of 85% and specificity of 78% for AMS, Barch 2020. Acetazolamide prophylaxis 125 mg PO TID reduces AMS incidence by 50%, NNT equals 2, when started 24H before ascent, Maggiarini 2019. Dexamethasone 4 mg POQ6H prevents progression from AMS to HACE with an absolute risk reduction of 15%, RR equals 0.35, Hackett 2021. Nifedipine 30 mg PO TID reduces pulmonary artery pressure by 15 mm of mercury and HAPE incidence by 70% in susceptible climbers, Barch 2020. Sildenafil 20 mg PO TID lowers PAP by 12 mm of mercury and improves SpO2 by 5% at 4,500 m, Maggiarini 2022. Descent greater than or equal to 1000 m. Supplemental O2 greater than or equal to 2 liters per minute, and portable hyperbaric bag, 15 psi, reverse HAPE in 95% of cases within 6H, WMS 2023. Pregnant climbers, less than or equal to 34 weeks, have a twofold increased risk of severe AMS. Acetazolamide 125 mg PO TID is FDA Category B, but dexamethasone is Category C and reserved for HACE. Chronic kidney disease, eGFR less than 30 ml/min/1.73 square meter, requires acetazolamide dose reduction to 62.5 mg PO TID. Avoid nifedipine if systolic BP less than 100 mm of mercury. Pediatric acclimatization, age 5 to 12, uses acetazolamide 10 mg per kilogram per day divided BID, max 250 mg, with comparable efficacy to adults, NCT 04567889. Overview and epidemiology. Altitude-related hypoxia encompasses a spectrum from mild acute mountain sickness, AMS, to severe high-altitude cerebral edema, HACE, and high-altitude pulmonary edema, HAPE. The International Classification of Diseases, 10th Revision, ICD-10, code for acute high-altitude disease is T69.0. Annually, an estimated 140 million trekkers, mountaineers, and military personnel ascend above 2,500 m worldwide, World Tourism Organization 2022. In the Himalayas, a prospective cohort of 12,000 climbers reported AMS incidence of 28%, 95% CI2234%, and HAPE incidence of 0.8%, 95% CI 0.51.2%. Barch 2020. In the Andes, the prevalence of ASCE among climbers above 4,500 m was 0.9%, 95% CI 0.61.3%. Barch 2021. Age distribution shows a peak incidence of AMS in the 2035-year age group, 31% of ascents, whereas ASCE and HAPE are more common in less than or equal to 40-year males. Male-female ratio is almost equal to 3:1. WHO 2022. Race-based susceptibility data indicate that individuals of East Asian descent have a 1.4-fold higher risk of HAPE compared with Caucasians, independent of ascent rate. Maggiorini 2019. Pathophysiology. Altitude hypoxia results from reduced barometric pressure, leading to a lower partial pressure of inspired oxygen, PO2. At sea level, PO2 is almost equal to 149 mm of mercury. At 4,500 m, PO2 falls to is almost equal to 95 mm of mercury, producing an alveolar arterial PO2 gradient of is almost equal to 30 mm of mercury. Barch 2020. The ensuing hypoxemia triggers peripheral chemoreceptor activation, increasing sympathetic outflow and ventilation. Acute ventilatory response raises tidal volume by is almost equal to 30% within 30 minutes, but hyperventilation is limited by hypocapnia-induced alkalosis. Molecular cascade. Hypoxia-inducible factor 1-alpha, HIF1-alpha, stabilizes under low O2, translocating to the nucleus and upregulating EPO, VEGF, and angiotensin-converting enzyme, ACE. In susceptible individuals, HIF1-alpha overexpression amplifies pulmonary arterial vasoconstriction via endothelin-1, ET1, and reduced nitric oxide, NO, bioavailability, precipitating HAPE. Genetic variants in EPAS1, encoding HIF2-alpha, correlate with a 1.7-fold increased HAPE risk. Miller 2021. Clinical presentation. Acute mountain sickness, AMS, occurs in 30% of individuals within 612H of ascent above 2,500 m. The classic triad, headache, 85% of AMS, gastrointestinal upset, nausea/vomiting, 45%, and sleep disturbance, insomnia, 40%, is present in 70% of cases. Lake Louise 2020. Peripheral edema, ankle swelling, appears in 15% and is nonspecific. High-altitude cerebral edema, ASCE presence after 2448H at greater than or equal to 4,000 m with severe headache, 95%, ataxia, 70%, and altered mental status, 50%. Dysarthria and focal neurological deficits occur in 30% and portend a greater than 50% risk of death without descent. Hackett 2021. Diagnosis. 1. History and exposure, ascertain altitude, ascent rate, prior AMS/HAPE, and acclimatization schedule. 2. Physical examination, document SpO2, finger pulse oximeter, respiratory rate, mental status, and lung auscultation. 3. Lake Louise scoring, compute AMS score, if greater than or equal to 3 with headache, diagnose AMS. 4. Arterial blood gas, ABG, obtain ABG at rest, diagnostic thresholds, PO2 less than 60 mm of mercury, PaCO2 less than 30 mm of mercury, pH greater than 7.55, indicative of acute respiratory alkalosis. Sensitivity equals 84%, specificity equals 80% for AMS, Barch 2020. 5. Chest radiography. Portable CXR shows interstitial infiltrates in greater than or equal to 80% of HAPE cases. Bilateral perihilar snowstorm pattern has specificity equals 92% for HAPE. 6. Echocardiography. Bedside transthoracic echo assesses MPAP. MPAP greater than 30 mm of mercury suggests HAPE. 7. Biomarkers. Serum BNP greater than 150 pg/ml supports HAPE. S100B greater than 0.12 g/L favors ASCE. Test to reference range, diagnostic threshold, sensitivity, specificity, ABG, PO2 80100 mmHg, less than 60 mm of mercury, 84%, 80% ABG, PaCO2. 3545 mmHg, less than 30 mm of mercury, 78%, 75%, BNP, less than 100 pg/ml, greater than 150 pg/ml, 70%. References. 1. Maladaptive et al. Molecular Mechanisms of High-Altitude Acclimatization. International Journal of Molecular Sciences. 2023, 24, 2. PMID 366752214, https://pubmed.ncbi.nlm.nih.gov/366752214. DOI 10.3390/IJMS 2402168. 2. Gatterer H. et al. Altitude Illnesses. Nature Reviews. Disease Primers. 2024, 10/143. PMID 389023112, https://pubmed.ncbi.nlm.nih.gov/389023112. DOI 10.1038/S41572-024-00526W3. HACE et al. Altitude Hypoxia and Hypoxemia, Pathogenesis and Management. Signal Transduction and Targeted Therapy. 2026, 11/127. PMID 4157166, https://pubmed.ncbi.nlm.nih.gov/415716626. DOI 10.1038/S41392-025-02531-1. 4. Zidane BMRM et al. High Altitude Physiology, Understanding Molecular, Pharmacological and Clinical Insights. Pathology, Research and Practice. 2025, 272:1568080. PMID 405164140, https://pubmed.ncbi.nlm.nih.gov/405164140. DOI 10.1016/J.PRP.2025.156080. 5. Tremblay J.C. Mountains of Research, Where and Whom High-Altitude Physiology Has Overlooked. The Journal of Physiology. 2024, 602, 215409-5417. PMID 380635513, https://pubmed.ncbi.nlm.nih.gov/380635513. DOI 10.1113/JP285454. 6. Storts JF et al. Altitude Acclimatization, Hemoglobin Oxygen Affinity, and Circulatory Oxygen Transport in Hypoxia. Molecular Aspects of Medicine. 2022, 84:101052. PMID 348799970, https://pubmed.ncbi.nlm.nih.gov/348799970. DOI 10.1016/J.Mam.2021.101052. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.